Bismillah ar-Rahman ar-Rahim. Well, I should express my deep thanks and gratitude to the organizing committee in Mabarat Al-Safra and the managers in Mabarat Al-Safra and Novartis company that made this meeting possible. It's a great honor to share in this meeting today, and I would start by talking about guidelines in STEMI, ST elevation myocardial infarction, and we have to build in the new era of myocardial ischemia, we have to build regional systems of ST elevation myocardial infarction care, and this should be by gathered efforts in all institutions to help people during the first few hours of chest pain. Here's an algorithm how we are going to deal with myocardial infarction, ST elevation myocardial infarction. If you could trace the graph here, you'll find that ST elevation patients who is a candidate for reperfusion is either initially received in a BCI-capable hospital or initially seen at a non-BCI-capable hospital. If he is in a BCI-capable hospital, the patient should be referred immediately for primary angioplasty. There is no doubt about that. The patient should be transferred into the cath lab immediately. If he goes to the cath lab, he will undergo diagnostic coronary angiography, and the result will be either medical treatment, BCI, or CABG, emergent CABG. If the patient was received in non-BCI capable hospital, in this situation, we have to look at timing. If the patient first, we have to give fibrinolytic drugs in the first 30 minutes. But if the patient, we have to give fibrinolytic drug in the first 30 minutes in situation where the transfer of the patient to another center who is BCI capable is more than 120 minutes. So if the patient is going to lose 2 hours, more than 2 hours, to be transferred to a PCI capable hospital, the patient should receive fibrinolytic system on site. Or the patient will be transferred for primary BCI if the distance between the first medical contact and device time is less than 120 minutes. So if I can transfer the patient to a cath lab capable system in less than 2 hours, the patient can be transferred immediately for primary BCI. There is no need in this situation to give fibrinolytic system on site. If the patient will take more than this time gap, so the patient should have fibrinolytic treatment on site. Then the fibrinolytic therapy either gets successful or unsuccessful. If the patient have successful BCI, successful reperfusion, the patient can be transferred to a cath lab within 24 hours. If it is not successful, the patient should be transferred to a cath lab immediately. In the guidelines, it shows that all communities should create and maintain regional system of STEMI care that includes assessment and continuous quality improvement of the emergency medical system and hospital-based activities. Also, the ECG should be performed by emergency people at the site of first medical contact. Reperfusion therapy should be administered to all eligible patients with STEMI with symptoms onset within the prior 12 hours. So a patient عنده myocardial infarction within 12 hours, the patient should receive reperfusion. Primary PCI is a recommended method of reperfusion when it can be performed in a timely fashion by experienced operators. Emergency medical support transport should directly to a PCI-capable hospital. For primary PCI is the recommended triage strategy for patients with STEMI with an ideal first medical contact to device time system goal of 90 minutes or less. So if you can gather your team within 90 minutes, this is a fruitful option for the patient. Immediate transfer to a PCI-capable hospital for primary PCI is a recommended strategy for patients with STEMI who initially arrive at or transported to a non-PCI-capable hospital with a first medical contact to device time system goal of 120 minutes or less. In the absence of contraindications, fibrinolytic therapy should be administered to patients with STEMI at non-PCI-capable hospitals when the anticipated first medical contact device time at a PCI-capable hospital exceeds 120 minutes because of unavoidable delays. When fibrinolytic therapy is indicated or chosen as a primary reperfusion strategy, it should be administered within 30 minutes of hospital arrival. Reperfusion therapy is reasonable for patients with STEMI and symptom onset within the prior 12 to 24 hours who have clinical or ECG evidence of ongoing ischemia. Primary PCI is the preferred strategy in this population. So we can apply primary angioplasty to STEMI patients within the range of 12 to 24 hours, but it's better to be within the first 12 hours. The relationship between sudden cardiac death and STEMI. Immediate angiography. Any patient with sudden cardiac death with a prior ECG of STEMI, we have to angio him immediately. And PCI, when indicated, should be performed in resuscitated out-of-hospital cardiac arrest patients whose initial ECG was STEMI. In cases of PCI-capable hospital, reperfusion is a primary PCI. Primary PCI should be performed in patients with STEMI and ischemic symptoms less than 12 hours. Primary PCI should be performed in patients with STEMI and ischemic symptoms of less than 12 hours duration who have a contraindication to fibrinolytic therapy irrespective of the time delay. So if the patient has any contraindication with fibrinolysis, like recent strokes or resuscitation from CPR or bleeding peptic ulcer or so, the patient should have primary PCI even if the time delay is marked. Primary PCI should be performed in patients with STEMI and cardiogenic shock or acute severe heart failure, irrespective of time delay from the myocardial infarction onset. Primary PCI is also reasonable in patients with STEMI if there is clinical or ECG evidence of ongoing ischemia between 12 and 24 hours after symptom onset. But it should not be performed in a non-infarct artery at the time of primary PCI with STEMI who are hemodynamically stable. So it's very important to note that in the case of acute myocardial infarction, when the thrombus is fresh, we are doing PCI to the infarct-related artery. We are not going to touch any other artery until the prothrombotic state of the patient calm down, and at this situation, we can tackle other arteries. But in the first instance, when we have acute myocardial infarction, STEMI, we have to tackle the infarct-related artery alone. And this is of financial impact because the patient have to go into the cath lab for another time. But we cannot revascularize totally the vessels at one setting. Usually when we have a STEMI, there is complete occlusion of any artery, and we have to use aspiration thrombectomy. We use a catheter that can aspirate the blood clot, as you just seen in the film. A blood clot can be removed from the vessel and open the way to put the stent. And this will save us a lot of non-necessary stenting, because if you aspirate the thrombus, you can decide exactly where is the lesion. If the artery is totally occluded and you are not seeing anything, and put a stent, you can put 3 or 4 stents and still you get no reflow. So aspiration is very important to decide where to put the stent. Use of stents in STEMI. We can use either bare metal stent or drug-eluting stents. We use usually bare metal stents in cases where the patient is at high bleeding risk. So the patient is having an active peptic ulcer or having esophageal varices or whatever. This patient is markedly exposed to bleeding risk, and in such situation, if you put a drug-eluting stent, you have to keep the patient on antithrombotic treatment like Plavix or clopidogrel for at least 12 months, or the stent will get clumped and closed. So in this situation, if the patient is having a bleeding problem, we have to give the patient a stent that can take about 1 month or 3 months maximum of antithrombotic treatment. So, but drug-eluting stents should not be used in primary BCI of patients with STEMI who are unable to tolerate or comply with the prolonged course of double antiplatelet therapy because of increased risk of stent thrombosis with premature discontinuation of one or both drugs. Sometimes we use adjunctive antithrombotic treatment and always we use aspirin in this dose, 162 to 325 milligrams, should be given before BCI. After BCI, the aspirin will continue indefinitely. We usually use to load the patient with clopidogrel, 600 milligrams on the first medical contact, in order to pave the way for the procedure and prevent intra-procedural thrombosis of the stent. You can apply, if you do not apply Plavix well, you can have a problem while putting the stent. You can find that the stent is closing by thrombosis again. And you open another artery, you find the first artery is closed, and so on. So you are dealing with a muddy situation where you have to prepare the patient well. We can use other antithrombotic, antiplatelet treatment like prasugrel or ticagrelol, but these agents, these chemical substances are not yet in clinical practice in Egypt. Also, it is reasonable to use 81 milligrams of aspirin per day in preference to higher maintenance doses after primary PCI. In acute myocardial infarction with ST elevation myocardial infarction, we better use antiplatelet therapy, intravenous antiplatelet therapy, which is highly effective in preventing the dissolution of the clot and no reflow after the procedure, like tirofiban. This is the most common drug we use, tirofiban, and sometimes we use eptifibatide as an intravenous antithrombotic agent. It's also reasonable in the guidelines to administer intravenous glycoprotein 2B3A receptor antagonist in the pre-catheterization laboratory setting to patients with STEMI for whom primary PCI is intended. So it's always, if you are planning for primary PCI, you better use tirofiban beforehand. As regards anticoagulant therapy, we use either unfractionated heparin or bivalirudin. Bivalirudin is just coming to the market in the coming few months, But in this situation, we are using unfractionated heparin according to activated clotting time. In patients with STEMI undergoing PCI who are at high risk of bleeding, it is reasonable to use bivalirudin monotherapy. This is the point where bivalirudin is indicated, but it's not yet to the medical practice yet in Egypt. In case of reperfusion at non-PCI capable hospital, fibrinolytic therapy should be administered. If the anticipated delay to performing PCI is more than 120 minutes, as we just said. But put in mind that fibrinolytic therapy should not be administered in patients with ST depression, except when a true posterior MI is suspected or when associated ST elevation in lead AVR. So it is very important to note that if you have non-ST elevation myocardial infarction, you should not apply fibrinolytic therapy. Because if you apply fibrinolytic therapy, you might transform the non-ST elevation into ST elevation myocardial infarction. So you are completely occluding the artery if you are giving fibrinolytic therapy, because it will uncover the receptors of the platelets and would help platelet aggregation. Also the same, we are giving aspirin and clopidogrel. Anticoagulant therapy, adjuvant anticoagulant therapy with fibrinolysis, we use unfractionated heparin, as I just said. We can use enoxaparin, and we can use fondaparinux. And then we have to transfer to a PCI capable hospital after fibrinolytic therapy. So even if fibrinolytic therapy is successful, you have to transfer the patient to undergo catheterization within 24 hours. So there is no, this is not correct when the patient it's a common saying that if the reperfusion therapy has happened by the fibrinolytic therapy, you can take your time until you go to a PCI capable hospital. This is completely wrong. Within 24 hours, you have to transfer the patient to the PCI capable hospital, because there is a possibility of about 40% recurrence or reinfarction at the same site within the first month after the attack. In case of delayed response, the coronary angiography in patients who initially managed with fibrinolytic therapy and did not receive reperfusion, the coronary angiography with the intent to perform revascularization is reasonable in patients with evidence of failed reperfusion or reocclusion after fibrinolytic therapy. Coronary angiography is reasonable before hospital discharge in stable patients with STEMI after successful fibrinolytic therapy. Angiography should be performed when logistically feasible. This I just said that in patients with in the acute attack, we only revascularize the infarct-related artery, except in cases of cardiogenic shock. Here we have to open all the arteries as much as we can in order to salvage the myocardium. Delayed PCI is reasonable in patients with STEMI with evidence of failed reperfusion or reocclusion after fibrinolytic therapy. PCI can be performed as soon as logistically feasible at the receiving hospital. Delayed PCI should not be performed in asymptomatic patients with 1 or 2 vessel disease if they are hemodynamically and electrically stable and do not have evidence of severe ischemia. PCI of non-infarct artery before hospital discharge, this is optional. It is indicated at a time separate from the primary PCI. So we are revascularizing the patient in the primary situation, and then we try to open the other non-infarct related artery at another setting. BCI is reasonable in non-infarct related artery at a time separate from primary BCI in patients with intermediate or high risk on non-invasive testing. The same schedule for antithrombotic therapy. Anticoagulant therapy to support BCI after fibrinolysis is the same, and we use intravenous unfractionated heparin and subcutaneous doses of enoxaparin. Fondaparinux, which is Arixtra, should not be used as a sole anticoagulant to support BCI, as additional anticoagulant with anti-2A activity should be administered because of the risk of catheter thrombosis. CABG, which I have the privilege to work with great surgeons in our hospital, that they can interfere anytime with our patients. Coronary artery bypass grafting in patients with STEMI. This is emergent CABG. It is indicated in patients with STEMI and coronary anatomy not amenable to BCI who have ongoing or recurrent ischemia, cardiogenic shock, severe heart failure, or other high-risk features. CABG is recommended in patients with STEMI at time of operative repair of mechanical defects. The use of mechanical circulatory support is reasonable in patients with STEMI who are hemodynamically unstable. Emergency CABG within 6 hours of symptoms may be considered in patients with STEMI who do not have cardiogenic shock and are not candidates for BCI or fibrinolytic therapy. Timing of urgent CABG. Aspirin should not be withheld before urgent CABG. Clopidogrel should be discontinued at least 24 hours before urgent on-pump CABG, if possible. Short-acting intravenous 2B3A inhibitors should be discontinued at least 2 to 4 hours before urgent CABG. Thank you very much.